going to take up too much of your time. So as Professor Bill said, my name is Tanya Hyland. I work in the Office of the Faculty Registrar doing student success programming, and I specialize in the area of accessibility and accommodation. And this is Tristan, who is working alongside me this year as a student staff member, again, helping us to develop some great programming and resources. And so today we just wanted to focus in on a few things. I know that in your course, I've seen that October has been called a few things, and one of them being Awkward October. And if we can get, I don't know if the slides are, yeah. Perfect, okay. So our goal in about 8 minutes time is to try and turn Awkward October around for you. We're going to do it in two ways. First, we're going to explain an idea called community resilience, and I understand that you've been learning a little bit about resiliency so far this year, and I'm just going to take it a little bit further and talk a little bit about this idea of community resiliency. And then we're also going to share some community-specific resources to help you navigate some of them so that you're able to access them much more easier. Okay. So you'll see checkpoint number 2 is the area that we're focusing in on right now. It's the area that perhaps has you feeling a bit turned around. Maybe you're feeling a bit unmotivated. I can see from the Notonic polls that some of you may not be sleeping as much as you would like to. You might be feeling a bit overwhelmed and behind with readings. And so one of the things that we want to do is to put some resources in front of you and help you navigate them during this time so that you're aware of them and also that you know how to then access them perhaps at a later time during your term. So really quickly, I want to share an idea with you. This is the work of Michael Ungar. He's a leading expert in resiliency. He's Canadian-based, and he's done a number of worldwide studies on what makes communities resilient. And I wanted to take some of that and share it with you today. If we see the first quote that he has here, resilience is as much about what we have, our individual and collective resources, as what we think, our mindset, which might be a bit different from how you've been thinking about or hearing about resiliency. Often it's expressed as a very individual trait that you have to either cultivate within yourself or that you have to somehow learn along the way. And it's just to acknowledge that many of you might be feeling that you're solely responsible for your own sense of resiliency. And we just want to point out that there's many ways in which resiliency can develop. And Ungar wanted to argue this a little bit further, and so if we move to the next box and we think about shifting the focus, to his definition is that community-based resilience recognizes the role that culture, context, and community play in developing our resiliency. So our role here today is in the third box. We're going to help navigate the role of the HMB community, the arts and science community, and then the larger UT community to help you know about the services and know how to access them when you need them. So when we think about the course that you're in right now, there's sort of 3 buckets that I came up with when thinking about building resiliency through a community. Obviously, you have a really caring and engaged instructor who brings you amazing snacks on a Wednesday, which is fantastic to see. I also know that you're often invited to social events, to having Thanksgiving together, to coffees, all of those sorts of things. Every one of those little sort of micro events is helping to build community amongst yourselves. There's also caring and engaged peers, the ones who are you're helping set up, the ones who are doing the weekly study guides for you, and who are there as your peers to help listen and navigate you towards resources. And then I know that some of you in the class have also formed recognized study groups as well. So for those of you who haven't yet joined one or who might be interested in learning more about them, there's 2 for this particular class that meet on Mondays from at 2 o'clock and at 4 o'clock. It's a really great way to meet your peers and to learn more about the course content and to spend some time together getting to know each other and also studying at the same time. And so just so that you're aware, all of the RSGs are open to any arts and science course that you might be taking, and there's still time to create or lead one for this term.
So I'm just going to talk about a bit of what we offer in our space. So the majority of our programming takes place in the Sydney Smith Commons, which is located at 100 St. George Street. So if you come in from the east entrance, we're just on the left side. And we're open every day of the week, and we close at 10 p.m. And then on Fridays we close at 7 p.m. So lots of time to come and stop in. So two of the main things that we offer in our space that we thought would be relevant are our online portal and then our learning strategist program. So if you visit our website, which I think because it's a common space for students, it's a bit unexpected that we would have online resources, but if you do search Sydney Smith Commons on Google, maybe put U of T in just to specify, our website will come up. So four major resources that are available on our website are our general programming information. So if you go to the website and click on our What's On link, you'll get a calendar explaining all of the programming that we're offering, including dates and times. So that's really good if you're curious about any of the information offered in our short presentation. But two things that I really want to highlight are the exam toolkit and help topics. So help topics is just a general sort of information page where you can get links to information that would be relevant for any undergraduate student and then also graduate students. However, relevant for this time of year is the exam toolkit. So essentially we've compiled a web page of important bits of information pertaining to exam writing and participating in exams. So I think a lot of things that, or something that's not really discussed is how often students are unable to attend exams or have issues concerning attendance to exams. And so this webpage really breaks down a lot of the formal pathways that you'll have to follow if you are unable to write an exam, as well as some of the bits of information that you might need to consider if you're in this situation, so as to just relieve that stress level and make sure that that information is available to you. However, if you're curious about any other information on our website, this year we started offering a live chat. So we'll always have a staff member available online to answer your questions. If they are sort of pressing issues, you can go onto our website and speak to somebody directly through our live chat function. Moving on to something that we do specifically in the space itself, we do host learning strategists, drop-in sessions with a learning strategist. So I'm not sure if you guys know this, but every college registrar does have a learning strategist available. So if you do go to your registrar, you can speak to somebody who can help you essentially plan your study approach and your learning approach for the semester. So essentially they serve to kind of help out with understanding ways through which to strategize how you'll go about dealing with coursework and preparing for exams and evaluations. So they're a really, really great tool, and in our space we offer drop-in sessions with learning strategists. So those would take place on Wednesday, every Wednesday, in our student common space. So those would be from 10 a.m. to 1 p.m. and 2 p.m. to 4:30 p.m. These are all available, by the way, on our website. This information is very accessible. You can come in and make an appointment with the learning strategist or just ask them a few questions in person, and they can help you address any issues or concerns you might have, regardless of whether you think it's relevant for a learning strategist or not. I still recommend coming in if you are unsure and talking to somebody, because they can also help you find out where to go if you do have concerns.
Okay, so lastly, just want to do sort of a larger review of the UT community-based resources. Some of you might be accessing these services, some of you might be using the tools, but if not, this is just yet another reminder of some of the great resources that are available for you. Coming up in December, we have Exam Jam, which happens in Sydney Smith Hall, which we encourage you all to attend. And certainly, if you have questions or you're interested in learning more about any of these, we encourage you just to pop online to the Sid Smith Online, and you'll be able to ask any of our Commons assistants there for more information about these resources, and they'll be able to help you navigate and find your way through any of these doors that are here. And so we only have like a minute left, and so what we want to do is find out if it's possible to rename Awkward October. So when we think about given that there's a lot of resources available to you, that you can go in and speak to your college registrar, that you can come and talk to one of us in the Commons, visit a learning strategist, those sorts of things. We're really hoping that we can kind of turn around this difficult time of year and encourage you to think a little bit differently about this time and know that there's resources and services available for you. And so I don't know that we don't have time for questions, but certainly just want to draw your attention to our website for the Sydney Smith Commons online. These slides will obviously be available to you. And then also recognized study groups is to really encourage you all to consider leading or joining the group to help you be successful this term. Thanks. Yeah, of course.
So, what would you tell a student who has planned out all of their deadlines, and they already know that they're not going to meet all of their deadlines? So they know they're kind of falling behind. It's been a lot more of a grind. Is there anything that you would suggest that they do?
Absolutely. So, two things. One is certainly to connect into your college registrar's office, and that way you can have a conversation with an academic advisor. There is a possibility of having what's called a letter of special consideration, where they can be sent to your instructor with the guidelines of requesting a little bit of extra time potentially for some of your assignments, and then also to come in and meet with a learning strategist. I, in a previous life, was a learning strategist, and it was one of the main things that I did was to help students manage their deadlines and to find out where can we shift things around, how do you spend your time wisely, when do you prioritize, and when do you let things go. And so those are the two tips that I would give.
That's awesome. Thanks so much. And just before we get into today's lecture, there's a really interesting competition coming up, and one of your classmates is going to tell you a little bit about it.
Hi, I'm Pavan, one of the co-presidents of undergraduate science-based competition for SciNaps. So SciNaps is basically a college-wide competition between university, master of Western, and University of Ottawa. And how it works is that you write a proposal on a topic, usually a scientific topic. So this year our topic is augmented biology. And after you write this proposal, it will be judged by judges randomly from one of these campuses that I mentioned. And the top 25% of the teams get to publish their proposal in undergraduate research for natural and clinical sciences and technology journal. The top 10% of the teams get to go to the University of Ottawa, where they will participate in a poster presentation and other scientific discussions, where the final winners will be determined. So register by the end of October. It's a great thing to put on your resume if you win, and overall it's a fantastic experience. Please check us out on our Facebook and our website, and we'll be glad to answer questions. You can contact us on Facebook. Thank you.
Awesome. Thanks, Pavan. Thank you. So if any of you are thinking of forming a team from HMB300, I'll actually pay for your registration cost, which I think is like $65. So I'm happy to pay for that. So we're going to dive right in. We have a lot of ground to cover today, so hopefully we can do that. So I'm going to go back and talk to you a little bit about depression. So depression is one of those topics that, again, a lot of you should be really upset about. Not in the sense that depression is going to impact you, because it probably will, but because we know so very little about depression. And in this genomic era that all of you are used to being a part of, not knowing how depression works, not knowing what sort of mechanism underlies depression is actually a really, really scary thing. Worse, we don't actually know how to see if someone has depression. We don't have that technology right now. So in a lot of ways, depression is one of those topics that we should get very, very angry about. One out of 3 students will have depression. And out of the entire population, 1 out of 4 individuals will have depression. To put things in perspective, that is much bigger than Alzheimer's, Parkinson's, any of the other neurodegenerative conditions that we're interested in. Depression dwarfs them. Like literally, it will affect everyone in this room at some point in time, whether it's directly yourself or someone in your family. And we know nothing about depression. And that, again, is very, very troubling. So I'm going to tell you a little bit of sort of an interesting area, similar to what we were talking about earlier, about things that we have to refocus. So since we don't know a lot about depression, we actually have to re-examine our understanding of depression. And we're trying. In the last few years, in the last 5 years, we have learned more about the biological basis of depression than in the previous 500 years that we've been studying depression in an evidence-based way. And so one of the things that I'm going to tell you that is really exciting that neurobiology has not done a great job on is to incorporate immunology into neuroscience. And that's sort of an emerging field and a very important field, and one that we're going to come back to several times over the course of the next few lectures. So one of the Nobel Prize laureates, because if you were in the last lecture, we talked about the dark Nobel Prizes and how the dark Nobel Prizes led to a lot of misunderstandings. We're actually going back and looking at some of the work that was done by Wagner Jauregg back in 1929. And he won the Nobel Prize in 1929 because he came up with this really interesting hypothesis that if you have a mental health concern or a mental health disorder, and he was looking at dementia caused by syphilis infections, that one of the ways that we could treat mental health disorders, in this case dementia caused by syphilis, was to induce the immune system. So he actually injected in a different parasite, activated the immune system, activated fever, and by activating the fever, all of the symptoms of dementia caused by syphilis went away. It was one of those really interesting studies way back in 1929 that was forgotten by science for well over 70 years. And then later, one of the other individuals that you see here, Dr. Yokin from Johns Hopkins, had a very interesting sort of segue back into looking at other possible causes of mental health disorders. And he thought maybe, just like we were looking at Alzheimer's disease, and maybe Alzheimer's disease may not originate in the brain. Maybe it originates somewhere else. Maybe Parkinson's disease does not originate in the brain. Maybe it originates somewhere else. But Dr. Yokin actually came up with this hypothesis that there's an overactive immune system that might somehow be responsible for generating a number of different mental health disorders, including things like schizophrenia and potentially things like bipolar disorder. And he was able to kind of elucidate some of those different pathways. And one of the direct consequences of that is Dr. Miyoka has actually been doing a lot of work, and he's been publishing on the fact that if you have someone, an individual who has a very, very severe form of mental health issues, like schizophrenia, and schizophrenia is sort of the test case for all mental health disorders. It affects 1 out of 100 individuals, by the way, so again, it's not a trivial disorder. 1 out of 100 individuals means that you will encounter individuals with schizophrenia on a routine daily basis. And one of the things that he found was that in individuals that had schizophrenia, that if he was able to take their bone marrow and do a bone marrow transplant, because they also had another condition like leukemia, if we got rid of leukemia by doing a bone marrow transplant, the signs of schizophrenia actually went away. And it was really one of those exciting things that he was able to link the bone marrow, the production of immune cells, and the disappearance of schizophrenia and all the symptoms of schizophrenia once that bone marrow transplant had been completed. One of those older antibiotics that are used to treat acne, for example, acne bacteria, or bacteria that causes acne, when he gave minocycline to individuals that had bipolar disorder, as long as they were on this antibiotic, they were actually okay. They didn't have any signs of bipolar, suggesting that an antibiotic working on some kind of factor, and possibly through the immune system, and he has no idea how it works, as long as they're on minocycline, they're fine, and as soon as they go off minocycline, they actually get worse. They get all the signs and symptoms of bipolar disorder again. So why are we talking about this? We're talking about this because we simply don't know what causes depression. We know that we can track changes in the brain if we're looking in the right place, but we still don't have a good diagnostic, and we have no baseline data for what causes things like depression. So we're going to start using our knowledge of neurobiology that you've built up over the last 2 to 3 years, and we're going to jump in and we're going to start looking at depression in a more logical way. And we're going to start going through what we know and what we've discarded along the way, and how we currently think about depression as we go through these different types of slides. We need to be able to treat depression. It is a very serious disorder. I know it may not sound like it's a serious disorder, but it is incredibly serious. It loses your productivity, it will impact your quality of life, and it can lead to very, very severe consequences as a result. And we'll get into some of the other theories along the way as well. And if I were to ask you one of those things for brain health, which was one of the earlier questions, how could you improve brain health? We're going to go back and start examining those using this model as a jumping off point. So sound like a plan? Is that all right? So we're going to just jump right in and we'll see how that goes. So our current model is actually one that is predominant now in neuroscience, that we tended in the 1990s to think of these different structures within the brain as independent units. So the amygdala was doing its own thing, and yes, it was connected, but we didn't really think of it as an integrated circuit. So how does the amygdala, even though we can't see a direct connection, how does it impact things like in the frontal lobe? And now we know that all of these things are indeed interconnected through a variety of different ways. So here's one of the slides that I need you to be familiar with. So we know that there's a circuit, and we know that there's a circuit that's incredibly important in some forms of depression. And I'm talking about some forms of depression because it's just like having a broken bone. So if I tell you I've broken a bone in my body, I can broken like any bone in my body. It could be a very severe, or it could be a minor fracture. There are many different ways to kind of explain that. And it's the same thing now for depression. When we talk about depression, it is not uniform. It is sort of discrete. It has its own sort of makeup, and we need to have that terminology, and we need to start thinking about that. These are very, very severe forms of depression, and in severe forms of depression, one treatment has been shown to work, and these are individuals where nothing, no drug, meditation doesn't work, nothing else is being helpful to them, and here we're looking at deep brain stimulation. We will have to surgically, neurosurgically, go in and alter the function of one of those circuits. And we need to know what part of the circuit to go in and influence. And one of the circuits that seems to be important in very, very severe forms of depression lies within this prefrontal cortex. So here is the frontal cortex here, and this small area, which is the subgenual cingulate cortex, a specific group of neurons in what is known as area CG25, is part of your normal circuit. When you are sad, there's going to be more activity in area CG25. So think back to last Wednesday, you're sitting around doing your group test, everyone's picking answer A, you're thinking answer B, your subgenual cortex is lighting up, right? And so that's sadness. Or if you see someone who's like really sad, then your subgenual cortex is also going to start responding in turn. So there is a sadness circuit, and this is part of that sadness circuit. And it turns on and it turns off, and it's part of the way that we deal with different types of emotions. However, in treatment-resistant individuals where nothing has worked, they tried every therapy, and this is like a last-ditch therapy for these individuals. This area of the brain, area CG25, is chronically activated. If you go in and you suspect that there's an individual who has suicide ideation, none of the drugs have worked, they've actually had a number of issues and hospitalizations, and you go in and you light up, or you go in and you do an fMRI, this area of the brain is going to light up without showing them a sad image, without getting them to think of term test 1 or anything else. This is going to be chronically active. It's going to be red hot. And we need to turn that down. They're sad all the time, and it's affecting their quality of life. And one of the things that can be done, and this is work by Helen Mayberg, who actually started off her career here in Toronto before heading down to the United States, was to use what is known as deep brain stimulation. We have to surgically, using neurosurgery, drill a hole and implant an electrode, guide the electrode to specifically this area and only to area CG25, and then using the electrode, turn off the activity of this area. And when this area is targeted and it's turned off in treatment-resistant individuals, most of them, not 100%, but more than 85% of these individuals actually don't feel the hopelessness that they used to feel. So this area, this circuit suggests that there are areas of the brain that we can go back in and manipulate. Do you have any questions on this before we go on? So area CG25, the CG part coming from the subgenual cortex, cingulate cortex, and this particular group of neurons which is chronically active in depressed individuals, specifically treatment resistant. Yes, Miriam.
Do you know what those neurons normally do when they're functioning in a not hyperactive state?
Well, so they are responding to emotions. We have neurons and we have other axons coming in from the limbic cortex that will directly activate these neurons. So they're part of your normal response. But it shouldn't be on all the time. Even if you're here at U of T, it should not be on all the time. Okay, so a couple of other things. So this is a study that was actually a landmark study. It's not been replicated, but it's really not that old. And it was a paper that came out in Nature Medicine. And there are lots of reasons why I'm kind of tagging this for you. So if you're looking for a really interesting paper and you happen to be more sort of inclined to psychology, or you're really interested in bioengineering, this is a great paper for you to do your visual summary on, or if you want to follow up and do some research on it. And here's this really interesting paper that came out that actually suggested that one of the things that I told you earlier, that there are actually multiple forms of depression. It's not just one depression. We can actually isolate 4 different biotypes. We can use fMRI, in a particular form of fMRI, known as resting state fMRI, where we can actually visualize how these circuits are connecting together or not connecting together. And by doing so, we can identify individuals that have certain forms of depression. The other reason why this paper is incredibly cool, this is the first paper that was published that actually used machine learning algorithms to help analyze the data. So they actually used artificial intelligence to analyze the data to track these different groups of individuals. And again, it's a really cool paper also because some of you may have had Professor Downer, who's in psychology. I believe he used to teach Psych 307. He was one of the authors on this particular paper. So it was sort of a homegrown paper that many people were interested in. Now, I don't need you to memorize everything on this slide. There are a couple of things that I want you to take away from this slide. So resting state fMRI is now a very, very strong and useful modality in terms of neuroimaging. So we're not actually asking you to think about anything. So it's a non-directed form. You're not asked to think about something in particular. You're just asked to kind of not think about anything specifically. And by doing this resting state where you're kind of daydreaming, not really thinking about anything while you're sitting in the MRI scanner, we can actually see what areas of the brain or what groups of neurons seem to be active and connected to each other. And this resting state fMRI gives us a way to measure connectedness and therefore an outline of the neural circuit that I showed you a little bit earlier on. So it tells us a little bit about the network or groups of neurons that are connected together. And we're not thinking of anything in particular. It's just resting. You're in there and you're kind of daydreaming or you're letting your mind wander. And it turns out that using this type of resting state fMRI, that Dr. Downer and others were able to find 4 different distinct groups of depressed individuals. So these individuals all came in, and their chief complaint, the reason for going into this study was that they had depression. And when they started analyzing all of the resting state fMRIs, they were able to group them into 4 different groups. And this also meant that this fMRI could potentially be a way to diagnose different types of depression. So remember I told you earlier, like if you break your bone, we can go in and take an x-ray and we know that your bone is broken. We don't have to guess. And so the guesswork involved in mental health disorders is a big issue. So resting state fMRI, if it turns out to be correct, and if people can validate and replicate these studies, might be a way to really quickly diagnose whether someone has mental health related issues in different areas of the brain. So particularly, the groups of neurons that are normally connected together between the striatum and the frontal cortex was one area that they were able to identify. There's a problem between the connections using fMRI between the frontal part of the brain and the striatal part of the brain. There's also connectivity issues between the limbic areas, so the hippocampus, the amygdala, and other areas, and the frontal cortex as well. And they could be diagnosed and they could be predicted to fall into these different groups. Who's having a hard time? Wow. Hope you're feeling okay. I hope you're not one of those 38 or 15% of students who are feeling sick. So it's a bad time to be sick, I know, but make sure you're taking good care of yourselves. And again, one of the things that's really, really cool is that these different biotypes or biosignatures are a way to predict if someone's going to respond well to medication, if they need to go in and get DBS, deep brain stimulation, which is a last-ditch resort for different things, or if they can use a non-invasive type of therapy known as repetitive transcranial magnetic stimulation, where a large magnet is put over the areas and circuits that seem to be affected. So this was a very, very cool paper because the potential to be able to diagnose individuals into biotypes that have depression using resting state fMRI could be like a big breakthrough. Now again, it hasn't been replicated, and for those of you who have studied anything related to machine learning or AI, know that not everyone uses the same algorithms, and they had their own algorithm, and it may not be reproducible in everyone else's hands, but it's something that I wanted to bring up. So I also wanted to clear up a couple of misconceptions as well. And one of these misconceptions is that depression doesn't always have to be like sadness. So some of you were asking, and again, I'm sharing that with you because I'm hoping that you'll allow me to have my own agency, and I'm happy to share with people, but please allow me to share with people when I'm comfortable doing that. So some of you have been asking, so do you currently have depression? To be honest, I'm not sure. My doctor's not sure either. But because I know that October and November are going to be really tough months, I am taking medication to try to offset any kind of mood disturbances. And for me, these mood disturbances are bad, but what's worse for me is I really can't concentrate. So I won't be able to remember things. My cognition is a little bit off. I feel very, very slow. And so to kind of offset that, I am currently taking Trintellix, which kind of has its own sort of side effects that we'll talk about later. So it doesn't mean that I'm always like sad. It doesn't always mean that I'm hopeless. I will tell you that I have a little bit of this anhedonia, which means that I do lack a little bit of motivation sometimes. And I'm really, really feeling, I'm really having a lot of difficulty concentrating, thinking, making good decisions or not good decisions, etc. But all of these things can be differences that manifest themselves in depression. So here's why. This slide is a really good example. We don't want to guess whether or not you have a broken bone. We have an X-ray. If that resting state fMRI is going to work, it will help to move people into these categories and give a more definitive diagnosis. So it's not just, well, how are you feeling today? Like, how long have you been feeling this way? And do you have like any strange thoughts or things that are going through your mind? So that's one of the reasons why I think that this neuroscience-based approach is incredibly important. So we're going back to the very beginning. So about 200 years ago, when scientists wanted to understand why people have depression, why it's not just sadness, but why people have depression, they basically started off with this slide. And this is sort of the slide that we're going to use to kind of take a look at our discussions. If you look at that previous slide, there are some things like eating, so there are weight disturbances, sleep disturbances, eating more, eating less. It can change in all sorts of different ways. These are basic drives, and these basic drives suggest that there's a circuit in the brain that gets it affected that involve basic feeding drives, or sleep-related circuits that might be affected as well. We know that there are cognitive disturbances, and for those of you who have taken a lot of psychology courses, you're thinking about the different parts of your brain that are involved in cognition, and you'll know that these circuits are probably not close to each other, but they have to overlap and they have to be involved with each other. So it probably means that if we're looking at some of these basic drives, the limbic structures, including the hippocampus, the amygdala, and potentially to get you to eat and find eating rewarding, these mesolimbic structures might be important in that. And the forebrain, the prefrontal cortex, might be important for cognitive disturbances. So we have these two different circuits that I showed you earlier, circuits that Helen Mayberg has been able to manipulate, circuits that the artificial intelligence driven paper in Nature Medicine by Drysden et al., they were able to show that these are the circuits that are involved. So this is really neuroscience. This is sort of classic neuroscience. So if we start looking at this from the same perspective that biologists have been doing, can we actually figure out what is going on in the brain? And can we also understand why we don't really know the mechanism behind depression really well? So one of the things, as I showed you earlier with Parkinson's, same thing with Alzheimer's, we don't really know the cause of depression. And that makes it really, really challenging. Depression, most causes are idiopathic. The one thing that we are relatively sure of, 95% of the different cases of depression are due to some kind of stressor. Usually you will not have individuals, there's a very, very small proportion, like 2% of individuals with depression don't have any stressor, so a loss of a job, loss of someone in your family, something bad happening to you, or multiple bad things happening to you, that could be the trigger that leads to depression, and that could be like over a long period of time, relatively short, and that accounts for like 95% of depression, but 2%, they just spontaneously fall into depression. And there's no genetics behind that, so it's still considered idiopathic, of unknown origin. So we don't know many of these causes of depression. We do know, however, that there is a biology associated with this type of depression. We know that hormonal imbalances can actually cause depression. And one of the things that I always recommend for all of you, so if you suspect that there's someone that has like a mental health issue, the first thing that you should do is just go in to see your GP and get a blood test, because some of these disturbances are really due to things that are hormonal in nature. It could be due to a lack of a vitamin. You have to get rid of those organic biology-based causes first before you can start thinking of depression. So these risk factors other than stress include changes in hormones. So that's one thing. We've known that for a very long time. Changes in hormones cause changes in mood, and some of those changes in hormones that cause changes in mood result in depression. Some forms of cancer, not because you have cancer and it's a very depressing diagnosis, but just having the cancer before you get the diagnosis can actually lead to depression. So you haven't gone in, you just are feeling really bad, you don't know that you have cancer yet, but having that tumor is enough to trigger depression in some individuals. And there are certain forms of cancer, some forms of breast cancer as well as pancreatic adenocarcinoma that can be the trigger for depression before you get that diagnosis that you have cancer. So there's some biology, there's something being released by these tumors that can cause changes within your brain. If you are getting treated with different types of drugs, isotretinoin as well as interferon alpha can also give you a lot of the same signs and symptoms of being depressed. So treatment with drugs, just like we saw with Parkinson's, treatment with toxicants can lead to Parkinson's. Treatment with drugs like isotretinoin and interferon gamma can also lead to the production of depression as well. The one caveat, and again, I'm telling you this at the beginning of the lecture, we're going to have to come back and visit it at the end of the lecture. We currently have no gene that is associated very, very strongly or correlates 100% with depression. So there's no gene, therefore we have no model, we have no organism, and we need to address that sort of right off the top. So I told you earlier on that one of the things that is known as a biological cause for depression is a change in hormones. And it was thought for a long time, so probably for about 50 to 60 years, that there was a hormonal basis for what causes depression. And I'm not trying to be derogatory in any sense, but if you look at the statistics, the prevalence of depression is much higher in women than it is in men. And so there was this idea that perhaps it's only hormonally driven, that all of this depression is hormonal. And there are a number of other hormones that we need to consider as well, not just sex-related hormones. So if we look at all of the different types of hormones, we know that stress is, for 95% of the different types of depression, it is going to induce depression. And if we look at the hormone that's often associated with stress, it's usually a glucocorticoid. And if you look at individuals that have depression, we will see small increases over the general population of glucocorticoid. Their basal levels of glucocorticoids are always going to be higher. In fact, although we don't have a genetic model organism, if we want to induce depression, we can actually induce different features of depression by injecting high levels of glucocorticoids, specifically corticosteroids. If we inject them into animals and we wait a little while, they will stop moving around as much. So for those of you who know anyone that's been affected with depression, one of the things that's really hard for students that are facing this is just getting out of bed in the morning. Like, they just don't want to. To be honest, I went through that a few years back too. Like, I just was not able to get out of bed. Like, literally my wife had to spend about half an hour, like, just get out of bed, go take a shower. It's really hard. And this immobility is taken as a sign that high glucocorticoid levels, activating the stress pathway at high levels for a long time, can result in immobility. So this immobility, this lack of movement, the motivation to move, is taken as a sign of depression. They will also just not press the bar levers as often. They just aren't motivated to move after this glucocorticoid. It's not a perfect model, by the way. They still don't have all of the other features of depression, but these two signs are definitely there. We know that there is a form of depression which is known as postpartum depression that seems to indicate that hormones might be involved, so anecdotal evidence of depression. And we know that depression is, again, associated more often with women than it is with men. And we know that if you look at the age ranges of females that are affected the most often, so it's about a 3-to-1 ratio between females to males that experience depression. And if you look at when they experience depression, most often it's between the ages of 15 to about 44 years of age. And that means that these different times of depression link up with the beginning of the menstrual period and the end of the menstrual period, where we get these changes in hormones. So again, anecdotal evidence, but this was the thinking for a very long period of time, that hormones drove depression. Of course, we know that that's not true. Men get depression, and it might be that 3-to-1 ratio that was so highly touted in the 1980s and 1990s, it just might be because men don't want to talk about depression. Like, it's better not to talk about it. It's better just to pretend that you're just tired, or you're just feeling angry, not because you're depressed, but because, like, other things are going on. And it might be that we've been misdiagnosing the levels. It may actually be closer to 1-to-1, maybe the same between men and women. We're really not sure. We do know that the rates of depression that's being reported is actually rising much faster in men than it is in women. So it might actually be that case. But this is sort of what people were thinking, that it's got to be biological in origin, and it has to therefore be just based on hormones. So glucocorticoids, one line of reasoning. The changes that occur in females at a specific age range, linking up to when we saw depression, again suggesting that hormones might be involved. And then if we take a look, and to me this is like really fascinating, there is a particular disorder that is known as Hashimoto's disease. It's also known as CLT, or chronic lymphocytic thyroiditis. This is an autoimmune disorder. So remember I told you earlier that now, in 2019, or actually starting in 2015, scientists were kind of going back thinking about the immune system and its impact on the brain, well, here's this sort of link as well. So this form of Hashimoto's is actually an autoimmune disorder. It's thought to originate as a celiac disease, so it begins in the intestines, and within the intestines, it's thought to originate the production of antibodies, particularly related to like a gluten diet. So if you have gluten in your diet, and you happen to be gluten sensitive, and you start to develop autoantibodies, these may result in the production of antibodies that lead to an autoimmune destruction and loss of some of the different parts of the thyroid gland. And if you take a look at what happens, well, one of the things that happens is your thyroid gland disappears. So you get hypothyroidism, which again makes perfect sense. But if you lose the thyroid gland, what else happens? Well, one, you just don't feel like moving, and you feel like you are going to be very, very sluggish. So you have fatigue, you feel tired, you feel slow all the time. Again, other things related to the thyroid hormone that hopefully make sense from a physiological standpoint. There's a lot more sensitivity to the cold, so thyroid hormones raise your basal metabolic rate. You will have a loss of skin thickness overall, but look at some of the other features of Hashimoto's that are not related to the biology of the thyroid hormone directly. So there's a lot of problems with anxiety in these individuals. There is trouble sleeping, so there's a loss of that basic drive that we talked about earlier. There is a change in their eating habits, and there's a change within their weight. It affects women more, and it also results ultimately in depression in these individuals. And again, if you reverse the loss of thyroid hormone, you're able to reverse all of these different features as well. So is it just a problem with thyroid? Well, it can't be, and it's one of the things that you go in for. So if you're not sure, you go in, you get your thyroid hormone levels checked, you get your glucocorticoid levels checked, and they'll do that blood test for you if you think that something's going on, and your GP will arrange all those tests for you. So another link with the endocrine system or hormonal system is Cushing's disease. So why don't we take a break now, because it is 5 o'clock. We'll take a good 10-minute break, and then I'll come back. We'll talk about Cushing's disease and Cushing's syndrome and how glucocorticoids might be involved. And where are you, Justin? So I think Justin has some stuff to kind of hand out to you. If you are deprived of snacks, there are a few left up here as well. So let's come back and meet at 10 after, and then we'll get going with some of the other hormonal evidence. awesome. Awesome. All right. Okay. All right. So we'll jump right back in, and if you can figure out, I know some of you are tempted. It has to be like all 4 of these things, but actually there is one clear-cut winner. There actually is one clear-cut winner that actually has 2 different effects on your brain health, and so it's actually like a really cool thing. So if you're looking at these different topics and you're looking at what actually is best for your brain, there is like actually a really clear-cut winner. All of these are good for your brain, but there's one that actually is even better for your brain, and then I'll come back and talk about that if we have time at the end, or I'll leave time at the end as well. So we were talking a little bit about how hormones became one of the theories originally, so probably long before any of you were thinking about biology or your parents were thinking about biology. The hormonal hypothesis for depression was actually a really predominant theory for a very, very long time in biology, and it was up until about the 1930s and 1940s. And then people started to rethink that, and we're going to examine like why that occurred. And the reasons why hormones might be involved are really like both experimental and anecdotal. So I talked to you just a few minutes ago about Hashimoto's disease. It definitely causes depression in individuals. It can be reversed by replacing thyroid hormones. There's a link between female sex hormones and depression, maybe, but it's really hard to tell. And if we go back to what we originally hypothesized, and we go back to glucocorticoids and stress, so stress causes the release of glucocorticoids. In another disease, by this definition, if stress causes glucocorticoid release and glucocorticoids might somehow be responsible for depression, we should see depression in individuals that have too much cortisol somehow in their blood. And in fact, if we take a look, Cushing's syndrome or Cushing's disease is one of those different types of disorders as well. So here's sort of the pathway that most of you are familiar with from physiology. So we have this small area in the brain under the thalamus known as the hypothalamus or below thalamus. And it's involved in releasing corticotropin-releasing hormone, or CRH, and it travels to the anterior pituitary gland, and from the anterior pituitary gland, it then causes the release of ACTH. And ACTH will then go throughout your bloodstream, and it will eventually, through the bloodstream, target the adrenal cortex, the adrenal glands. And after it targets the adrenal glands, it will cause the adrenal glands that are sitting on top of your kidneys to release cortisol. So if we use this classic pathway, and in Cushing's disease where we have an overproduction of ACTH, there's just way too much ACTH around, and they produce a lot of ACTH, and if you follow this pathway here, that means that they are producing a lot of cortisol all the time. They should have depression if our model is correct. And so if we look at Cushing's syndrome, there are a lot of things that we see with Cushing's. And with Cushing's, we see that there are emotional disturbances, including things like depression, and we see that. We also see a redistribution, and we see like a gain in weight. And often they are characterized by having a massive amount of fat deposition on the back of their neck, so they will have this buffalo hump. And again, they have a lot of other issues as well, but they do have things that resemble many of the features of depression. So cortisol could be a contender for why depression exists. And often what is used is a dexamethasone suppression test. So you're given a shot of dexamethasone. It should actually block the production of cortisol after you're given it if it's just due to ACTH levels. And if cortisol stays high, then cortisol levels are rising not because of ACTH, but something going on in the adrenal glands. So this HPA axis, as I mentioned at the very end of the last lecture, in lecture 4, I said that about 10% of the different causes of depression involve like changes to the HPA axis. it suggests that this basic pathway from the hypothalamus to the pituitary to the adrenal glands and then the release of cortisol is actually very important. And here we have way too much cortisol because we have way too much ACTH in this disorder. Can it get turned around if we get rid of or block the cortisol effect? And it turns out that that theory and hypothesis is actually correct. So a cortisol receptor blocker, I'm going to use the short form, and you can use the short form as well, RU46, can actually block the effects of Cushing syndrome, and it can also reverse many of the signs of emotional distress and emotional disturbances that these individuals have as well. So it suggests that in some cases, hormones do play a role, and we can't account for all of them, but we can account for cortisol, at least in this case. We might be able to account for other types of depression. If we don't look at it as one disease, but many, many different types of disorders, then maybe different hormones might play a role. But that's probably not the theory that you grew up on. And that's not the theory that has, up until about 10 years ago, been the theory that was put in the textbooks. And most of the time, we talk about a neurochemical imbalance. There's a change in neurotransmitter transmitter release. And there's a lot of evidence to suggest that there are not just structural changes that happen in the brain, but there is a change indeed in neurotransmitters. Is this the primary cause? That's the key issue. Is this the cause, or is this correlated to depression? So if it's the cause, fixing this will fix depression. If it's correlated to, fixing it might fix this, but it may not actually address it right away. So what is sort of the theory behind all of this? So many of the different types of systems that are affected in depression, so now we know at least there are 4 biotypes. If we look at the systems that are affected in the 4 biotypes, we can actually identify all of the systems, whether it's limbic or whether it's frontostriatal or whether there are different circuits only within the limbic system. We can identify things like dopamine, that's a biogenic amine. So motivation, dopamine, that's affected in depression. We know noradrenaline is affected in depression. That is also a biogenic amine. And so is serotonin. It's also affected in depression as well. And so these change. In fact, we can demonstrate and we can show that in a depressed individual, that overall, through PET scanning and examination of different neurotransmitter release, that we can show that there is a change in the neurotransmitters that are available in depressed individuals. It goes down versus a normal individual who is not experiencing a mood disorder. And again, many substance abusers that stimulate that dopaminergic pathway, that drive excess amounts of dopamine, they also will experience signs of depression as well. So this is sort of the anecdotal evidence that we now use to kind of say that, yeah, we have a lot of evidence to suggest that it's neurotransmitters. I'm going to suggest to you that it's not the cause, but it can be strongly correlated with depression. So it may not be the cause, that's not why we get depression, but as we get depressed, we will see a reduction in neurotransmitter release. So if that's the case, why is everyone, up until about 10 years ago, why is everyone so excited about this neurochemical hypothesis? So let me take you back through time, all the way to the 1950s. In the 1950s, this is the first golden age of neuroscience. This is where neuroscience actually becomes neuroscience. Before that, there were a lot of neuroanatomists, there were people looking at different stains, there were lots of psychologists, there were lots of people examining individual structures, but in the 1950s, this is where neuroscience as a discipline actually originated. And neuropharmacology came into its own, the anatomy, behavioral biology, all of this started in the 1950s. So a lot of the evidence that we still use up until like 2010 came from all of these classic experiments from rats and different animals that were identified in the 1950s. Also, from the classic experiments that were done at McGill University by Wilder Penfeld and stimulation of different areas of the brain that showed that some areas were more important for behavioral responses, pleasure-seeking responses when he stimulated them during neurosurgery, all of that data came from the 1950s, suggesting that dopamine plays a role in pleasure, that certain areas of the brain, like the nucleus accumbens, are important. So going back, in the 1950s, there was a huge explosion in the number of neurochemicals that were being systematically developed. And one of the big issues in the 1950s was that people were dying from like heart attack and heart disease. So it's still a problem today, but it was a really big problem in the 1950s. And so scientists started to develop different types of drugs based on their knowledge of neurochemicals or chemicals that were involved in how your heart beat and how different drugs could be delivered to specifically reduce blood pressure, which was correlated with people dying from heart attack as well as stroke. And one of these drugs was actually reserpine. And reserpine is one of those drugs that will actually reduce, it's an anti-hypertensive, so you know that your heart, the cardiac accelerator nerves release noradrenaline. It causes your heart to beat faster. It causes it to contract more forcefully. That raises your blood pressure. And reserpine was there to take away noradrenaline. So it depletes noradrenaline, which is a monoamine. So monoamine equals biogenic amine equals noradrenaline. So this drug was developed to reduce high blood pressure. It was an antihypertensive, and it depleted noradrenaline. And it was thought that, okay, we'll deplete noradrenaline at the level of the heart. That will slow the heart rate down. It will also reduce sympathetic nervous system tone. It will also cause people to have lower blood pressure. And it worked. It actually is very good as an antihypertensive. The problem is, when scientists started to look at the effects of these drugs in humans, not in animals, but in humans, they realized that many of these individuals that were feeling better because they no longer had high blood pressure were now starting to feel depressed. So how could a drug that affects noradrenaline, that is reducing the levels of biogenic amines, how could reductions of biogenic amines cause depression? That was the key question that scientists were asking in the 1950s. There were also other drugs that were being developed, and one of the drugs was actually iproniazid. And iproniazid was a drug that was first developed in the 1950s to combat tuberculosis. So tuberculosis is no longer one of those public health disorders in most countries, but tuberculosis was a big deal in the 1950s. If you had tuberculosis, it was very contagious. People were very worried about contracting it. If you developed it, you would likely die from different complications from tuberculosis. And so one of the drugs that was developed was iproniazid, and iproniazid was a very, very effective tuberculosis drug. The problem, or the good thing about iproniazid, was that when people who were taking iproniazid for tuberculosis were interviewed later, they all felt like they were in a much better mood. So they felt happier. So here's this drug that is designed to block tuberculosis that's actually affecting mood. In vitro studies also suggested that it was probably affecting some of those biogenic amine pathways, so noradrenaline, dopamine, as well as serotonin. So with all of these different drugs, originally purposed for different uses, now having an effect on mood, sometimes causing depression, or in the case of iproniazid and later imipramine, which is the first tricyclic antidepressant developed, these drugs were actually able to change mood by changing the overall levels of these different neurotransmitters. And that was, again, shown much later, but the results were shown in the 1950s. Scientists going back in the 1960s, a decade later after these drugs had come out, showed that there were specific areas in the brain that responded really well to these different types of drugs. We could change the amount of noradrenaline. We can deplete it, or we can increase the levels of serotonin, or we can change some of these biogenic amines. Do you have any questions so far, or anything that I can clear up for you now before we kind of move on? And I'm going to talk a little bit about this specific slide. Yes, Miriam. So the question that we have here at the front is that does reserpine reduce the levels of biogenic amines? Specifically, was trying to reduce noradrenaline, and it does. So it does reduce noradrenaline levels. Originally was intended only to block and reduce levels of the monoamine noradrenaline in the heart, but it also affects the brain. So in the brain, noradrenaline and other biogenic amines also go down. And iproniazid, which was originally designed for tuberculosis, actually elevates levels of different neurotransmitters. If it's a really quick question.
Are there any modern antidepressants that mimic the drugs that you mentioned that
No. So most drugs now are the new generation of SNRIs or SSRIs. They're more to increase at the synaptic level by blocking different reuptake channels or transporters. They're not designed to actually block MAOs or any of the other ones. Those are the original classes of drugs. So again, going back, there's some more anecdotal evidence that is used. And if we take a look, so here is the norepinephrine system that I just mentioned. So reserpine would be affecting this particular system. So reserpine reduces the level of the noradrenaline, and this is noradrenaline or norepinephrine. There are two major neuronal tracts within the CNS. And again, it's all anecdotal, but there's a lot of accumulated anecdotal evidence that led to this neurotransmitter or neurochemical hypothesis. One of these groups of neurons within the brain is known as the locus ceruleus, so down here at the level of the midbrain. And then we also have a group of neurons known as the lateral tegmental neurons as well. And it's not as clear on this particular diagram. So these are small groups of neuronal cell bodies. They're responsible for synthesizing and releasing norepinephrine. And these long arrows that you see emanating out from the locus ceruleus are their axons, these axonal tracts. So they're delivering norepinephrine or noradrenaline to all of these areas within various parts of the brain. So even though we have a very small group of neurons that produce noradrenaline, it has a tremendous impact in a large group of neurons that are affected because of how these axons come out and then make connections to other groups of neurons throughout the brain, including the cerebellum, etc. So why are all of these different things important? Well, one of these bundles, which is the dorsal bundle and the medial forebrain bundle, actually control a lot of the circuits that I mentioned to you at the outset. So they're sending projections, but they're also making other connections along the way. They're connecting different parts of the midbrain to the frontal cortex, and along the way, they're also making other synaptic connections. And these are the tracts that are thought to be involved in vigilance or alertness. So we know one of the things that happens in depressed individuals is that overall, like, they are more tired, more fatigued, sleepy, sluggish, etc. They're going to have sleep disturbances. And again, just to share with you, I've had two very, very different exposures to depression. The very first time, I had like major sleep disturbances where I just literally could not sleep. Like I really wanted to sleep, but I could only get about 2 or 3 hours of sleep per night. The second time that I had depression, including up till now, my sleep isn't affected at all. Like I sleep fine, but there are other things that I didn't see the first time around. But we know that sleep is often affected in things like depression, and here's this biogenic amine that is involved in controlling these sleep-wake cycles or modulating these sleep-wake cycles. Again, if you feel unmotivated, this is also, these pathways are involved in reinforcing the behaviors for reward. If you take a look at this area of the brain, this dorsal adrenergic bundle, if you happen to get a stroke right here, so you get a focal stroke in this area of the brain, in the forebrain, you will actually develop a very, very interesting form of depression. So you will have specific depression if you disrupt this axonal bundle. Nothing else is going to be affected, your motor movements, nothing. And again, you're thinking, is this near area CG25? It's not area CG25, but it is indeed very, very close to it. So all of these things are all anecdotal. There is really no one solid piece of evidence that everyone can agree to as to why we think that this is the pathway that is so important. Yes, yes. So Anecdotal meaning that it's not really evidence-based, but you hear a lot of people talking about it. So are Oreo cookies good? Is there evidence that Oreo cookies are good? No, but many of your friends will say that, yeah, Oreo cookies are good. That's anecdotal evidence, word of mouth type of evidence. And even in the scientific literature, sometimes case reports, case studies, those aren't really evidence-based, but they're anecdotal sort of pieces that people can refer back to. Okay, so now in sort of the modern era of neuroscience, where we're looking at the 1970s, 1980s, where we know a lot more about synapses and how neurotransmitters can get synthesized, what causes the breakdown of neurotransmitters, where some of these drugs are now acting. So people didn't know in the 1960s. They kind of saw, oh, these things are going up or they're going down. And we know that serotonin's going up, or we know noradrenaline is going down. In the 1970s and 80s, people actually had mechanisms for how all of this worked. And much of that evidence actually suggested that if you altered different types of neurotransmitters at the level of the synapse, either by inhibiting their breakdown, so having like monoamine oxidase inhibitors, so MAOIs are monoamine oxidase inhibitors. They break down neurotransmitters. Or you prevent them being taken back up into the synapse after they've been released, so selective serotonin reuptake inhibitors, things like sertraline, which is also called Zoloft, or fluoxetine, or the latest class of dual inhibitors that inhibit both the uptake of norepinephrine and the uptake of serotonin. So you have both norepinephrine and serotonin at the synapse. It stays there for much, much longer periods of time because duloxetine actually inhibits both transporters for these presynaptically. These drugs have been shown to be beneficial for some individuals, not all. So not all people respond to antidepressants. So for those of you who have other individuals that you are aware of that have had depression, when they go in for a diagnosis and the doctor begins to write out a prescription for them, how long do they have to be on the medication before they might see a positive effect, where their mood is either better or some of the effects that they are experiencing get better? How long? About a month? Any other ideas? Yes, Adam? About 2 weeks? Yes. 6 weeks? So it varies from individual to individual, but a safe bet is somewhere around 3 to 4 weeks. And that may or may not work. And there are a lot of issues. So for those of you who have never been on antidepressants, that's great. So I had to, the very first time I was on antidepressants, it was not a pleasant experience because I felt dizzy all the time, or I felt very nauseous. And so they tried to put me on a different drug, then they tried different doses of the drug. So it is kind of a guessing game, which is why finding out what biotype people are will lead to a better sort of recovery as well as a better treatment. But it takes time. Is that weird or not weird? So imagine yourself, right? So you have a headache. What are you going to do if you have a headache? Tylenol. Okay. So imagine you have a headache and you take a Tylenol and it works 3 weeks later. Is that good? No. Right. So Tylenol works almost immediately. So it gets biotransformed, it gets transported up, and it works. So why does it take so much time for these drugs to work? Because we can see changes at the neurochemical level. So these things happen. Neurotransmitter levels go down. We see a reduction in serotonin in depressed individuals. We see a reduction in norepinephrine. We see reductions in some parts, for some individuals, of dopamine. And if they take an antidepressant medication for a couple of days, the levels in their brain go right back up. But they still feel depressed. Why? Any ideas? Yes? But if we do PET scanning, so I showed you an earlier PET scan where we saw in a depressed individual throughout the entire brain, we saw a reduction in different neurotransmitters compared to a normal brain. It is pretty global. And if we give an individual an antidepressant, they will actually show positive changes within a couple of days. And in some cases, within a few hours. But they don't feel better. Why? If it's only neurochemical, why don't they feel better? So I mean, if something feels hot and it's burning you and you take your finger away, it still hurts. So maybe that's the hypothesis. But I don't think so. And so a lot of scientists are very skeptical that it's only and just a neurochemical basis for this. So right now, those are sort of the major theories that we're kind of dealing with. So we talked about hormonal theories, and they do account for about 10% of the different forms of depression. And there is a biological cause, and hormones do have an effect on changing mood, definitely, 100%. And neurochemicals are correlated with changes in mood, but they can't be the only thing that's happening with changes in mood. And the other big thing that is really problematic, outside of that paper by the earlier group in Nature Medicine, we don't really have a good way to find out when someone is experiencing depression. So with all of this in mind, let's go back to what we started, like at the very beginning of the course. Let's deconstruct some of these theories and go beyond sort of the current theories, and let's look at some of these alternate theories that are also gaining traction, like they're coming in as alternate explanations. We don't have a cause, they're idiopathic, so let's look at other possible causes that go beyond just neurochemicals. So this is actually a fascinating hypothesis that was put out by Janice Clements a while back. And you don't have to worry about what's down here in red. I'm not going to address that this year. If you look at your genome, so again, you're born in the era of genomics. You are all children of the genomics era. If you look at your genome, all of you have about anywhere between 5 to 8% of your total genomic DNA actually has viral remnants that are embedded within it. So at some point in time, viruses have invaded the human genome, and they're still there. We see remnants of this viral genome. And one of the things that is very, very incorporated into our DNA are these different types of endogenous retroviral sequences. And these ERVs, endogenous retroviruses, are a very important part of our genome. So anywhere between 5 to 8% of everyone's genome here actually has been infected at some point in the distant past by these ERVs. And again, you think, well, that's okay, nothing wrong with that. And where those sort of insertions have occurred may be important, may not be important. So a lot of these different endogenous retroviruses that have invaded our genome in the past are ones that I'm going to be addressing. But just to give you some examples of retroviruses that are still shaping our genome to this day, HIV is an example of a retrovirus that is still shaping our genome. The human genome, not individually, but the large genome. Hepatitis B viruses are also being expressed as well. And one of the things that is in our genome, like universally human genome, is that we have very, very specialized endogenous retroviruses, which are known as Borna-like viruses. And these Borna-like viruses normally infect horses. And because in the distant past we've been interacting with horses and the viruses from horses have infected us and then been incorporated into our genomic DNA, we still carry the remnants that at some point we started to ride horses. So horse riding has led to the inclusion of these Borna-like N gene elements within our DNA. And again, no big deal, right? So why is all of this important? According to Janice Clements, this is important because this tells us about individuals who are susceptible to developing depression. So one thing that I haven't mentioned is that does everyone sort of have the same threshold for depression? Are there people that are never going to be depressed? And I'm going to show you later that there are people that will never be depressed no matter what happens to them. Like they are what we call resilient. And Tanya talked about it at the beginning. And these resilient individuals genetically probably don't carry the same elements that we have or have extra things in their DNA. So we'll come back and talk about that in a few moments. So let's get into these Borna disease viruses. So born disease viruses are neurotropic, meaning that they prefer infecting neurons. So neuronal DNA is particularly at risk for being infected and incorporating these born disease viruses. Many other endogenous retroviruses, but this is the one that we're going to be talking about. So Janice Clements came out with a science paper a while back, and it hasn't been sort of refuted. No one's been able to show that it's wrong. And some people have actually correlated, corroborated, and have expanded on her original study. And Janice Clements' paper actually says that some mental health disorders, including depression, and some developmental disorders, potentially like schizophrenia, are actually because of these remnants of these endogenous retroviruses that have been encoded into our DNA. Many of these mood disorders, according to her, can actually be attributed to where these retroviruses have inserted themselves in specific regions, in specific parts of our DNA. And why she says this is because one of these born disease viral proteins is known as phosphoprotein 24, abbreviated for you here as P24. And this is normally involved in, as the virus replicates and starts to spread to other nearby neurons, because it is neurotropic, so it replicates inside neurons and it starts to spread to other nearby neurons. Remember rabies virus? Remember that RABG question? No. You don't want to remember that RABG question? That's okay. But viruses do want to spread. And if you take a look, specifically in these individuals as they are experiencing a mood disorder or a psychotic incident, so as they're experiencing psychosis with schizophrenia or they're experiencing depression, there are certain groups of individuals that actually increase the levels of these phosphoproteins, like the phosphoprotein 24, from the blood of these individuals. They're producing a lot of it as they're experiencing this mood disorder. Now, why might that be? So she has a number of hypotheses, but it's fascinating to suggest that maybe mood disorders and mental health illnesses actually have to do with a genetic origin. And Janice Clements' paper was actually one of the first to suggest that maybe we can develop a genetic model for depression. All right. So, do you have any questions on anything so far, or anything that I can clear up for you? No? Okay. Okay. So let's take a little bit of time to take stock of what we're kind of looking at. So here's this really interesting sort of thing, and then you'll have to tell me if you agree or disagree with this. So if you look at depression, and this is like, it's an ongoing debate. So is there genetics associated with depression, right? So I told you that there's going to be resilient individuals. They will never develop depression. But if someone in your family has depression, does that mean that other people in your family will develop depression? So it's a controversial area. So if you look within families, there seems to be a correlation that if you have an affected individual, a closer relative might develop some kind of mental health related disorder, or they might have schizophrenia, they might have undiagnosed schizophrenia. So it suggests that there is some genetics, there is some heritability associated with mental health disorders. If you look at identical twins, and in identical twin studies, here's the other interesting thing. So if it's only genetics and it's purely genetic, then you would expect that if you have two identical monozygotic twins that carry the same DNA, and let's not worry about epigenomics or epigenetics, but let's assume that all of that is also identical, because not only have they been growing up in the same environment, but they're genetically identical, so everything is equal with these individuals, that you would expect that if one of the twins gets depression, that the other twin must get depression if it's only genetic. Does that make sense? But in fact, when we look, it's not the case at all. Only about 50% of a genetically identical twin will develop depression. If it was only due to genetics and genetics only, it would be 100%. Every single twin, the other twin would have depression as well. But it's only 50%. So it cannot be only genetics. So the current model that people have thought of is that there has to be a genetic vulnerability. So going back to Janice Clement's paper, not everyone has those insertions at the same place, and so not everyone is going to have phosphoprotein P24 being expressed when they have depression or if they're undergoing psychoses. And it suggests that it's genetics plus having environmental exposure that leads to them being more vulnerable. And why that is all really exciting and important is because of this particular landmark paper. And this, again, has been probably, in my experience, maybe the third or fourth most controversial paper published related to the brain, that at least that I'm aware of. And this landmark paper that came out almost 20 years ago, about 17 years ago almost, in Science, actually linked everything. It was like the perfect paper. So why is it perfect? So one, it says that there's genetics involved, but it's not only genetics. Two, it involves the serotonin system. So again, serotonin, neurotransmitter, genetics, but not only genetics. And it was also, at the time, one of the largest studies. Like, you laugh at this now because it's like 2019, you've grown up in the genomics era, and so you get to see like tens of thousands, hundreds of thousands of individuals enrolled in studies. But in 2003, if you had over 100 subjects in a study, that was considered a massive study. Here, they were publishing based on nearly 1,000 individuals, 847 individuals. And the short story to all of this is that they were able to identify a genetic variant that made individuals more susceptible to developing depression if they encountered stress. And it affected the serotonin system. And it was, again, a remarkable paper back in 2003. So all of these landmarks are really important. So I think most of you have kind of done the quiz question already. This is what we're looking at. This is the paper, the Caspi paper. They identified that the 5-HTT, the 5-HT transport gene, there are two different variants we all carry. So you have a short variant. And if we take a look, what is the difference between the long variant, the long allele, versus the short allele? And what's different is this blue region here, which is the variable nucleotide sequence that you see, this VNTR region that you have here. So you guys love Ken Yip? Love Ken Yip? I love Ken Yip. So what does the VNTR do? You love Ken Yip, but you can't remember everything Ken Yip told you. That's okay. Right. So everything else being equal, this is where we actually have the Tata box region. This is where transcriptional factors start to bind. So this is where we actually start gene expression, right? But this region here actually leads to the promotion of different transcriptional factors that will help. It's a promoter region, in other words, that helps to get the gene being expressed. So we're shortening the promoter region of this gene. Is that clear for everyone? So this is the promoter region. It is not the gene itself. There's no alteration in the gene. That would have been really, really cool, but they found no alteration in the gene after sequencing it. But they did find that people carried either a shorter promoter region or a longer promoter region. And the difference in this was that if you had the longer promoter region, you would actually be producing or capable of producing more of these serotonin transporters. And if you had the shorter allele, that you would have fewer of these transporters being expressed at the synapse. Again, it's a pretty remarkable story. And you can alter the effect of this. Under normal circumstances, you can get away, just like you can get away with like living with one kidney or one lung, you can get away with that. Having fewer numbers of these transporters will not affect you until stress hits you. And that's sort of the key element to this. Just because we're running a little short on time, you don't have to worry about the structure of the gene. You don't have to worry about memorizing anything here. I'd like you to make sure that on the previous diagram, that you know that it's in the promoter region, that 5' VNTR region is much shorter. There's no change in the gene length itself. The gene itself is perfectly normal between the two variants, and there's no changes in the TATA box or in the transcriptional factor binding regions. It's really the number of these transporters is different. But it became very, very controversial. And so what they did was these 847 individuals, they tracked and they genotyped them, they tracked them, and they wanted to know if you carried the short version or you carried the long version, and at some point in time, if you carried one or the other, and something bad happened to you, if you hit stress, would you develop depression? And when they looked at this prospective study, so they started off with these young individuals and then tracked them over time, a prospective study, what they found was if you had the short version and you encountered stress, and that was important, only if you encountered stress would you develop depression. If you had the long version and you encountered stress, you would not, or you were less likely to develop depression. And that was sort of the really cool finding. So I'm going to come back in the next lecture and then pick up where we're leaving off here. Again, it's controversial because not everyone agrees with that, and we're going to talk about what that means in terms of science. Just going back to this really quick poll. So who do you think is right? What's best for your brain? Sleep. Why do you think sleep? That's when your brain recovers. Why does your brain recover when you sleep? Any ideas? It's actually correct, but there are two factors. Yes? Sorry, more? So more inhibition during sleep? Okay, possibly. Anything else? Yes? Removal of removing neurons, not good. Anything else? Yes? Okay. So let me just give you a really quick rundown. So sleep is where is at the time where your lymphatic system, the lymphatic system actually gets to clean out your brain. And in addition to that, this is where your synapses get to rebuild. So you're tearing down. Imagine standing up all day. Your ankles are going to be tired, your knees are going to be tired, you need to rest. Same thing as your neurons. You might think that they never need to shut off, they do. So we now know that in 2019, you have to rebuild synapses and the key components. But more importantly, this study that came out earlier this week actually shows that if you are sleeping, this is where your immune system can actually help and remodel parts of your brain. And without that immune system, your brain can't really fully recover. And there's a specific type of T cells that we're going to be talking about later on that actually make its way up into your brain while it's sleeping or while it's resting to help you to reset your brain and to help you develop better immunity within your brain. So I won't see you for about a week, so have a great week. If you have any issues with your assignment deadlines or anything else, please reach out to both myself and the TAs. We'll talk about it. If you're writing the term test, the makeup term test, it will be on Friday, 12 o'clock in Wilson 1017. Have a great week, everyone. See you next Wednesday. Okay, so we're good here?